Absolutely. You are on.
Yes. Okay. Good evening, everyone. Mental health is not just absence of illness. It is the foundation of emotional strength, resilience, and overall well-being. And today, we are truly privileged to have with us the speaker who embodies this commitment to mental health care and awareness. It is my honor to introduce our esteemed speaker, Dr. Aishwarya R. Kamath ma'am. Dr. Aishwarya ma'am is senior resident in psychiatry with MD qualifications and trained at Government Medical College, Thiruvananthapuram. She is currently associated with Amrita Institute of Medical Sciences, Kochi. Her areas of expertise include de-addiction psychiatry, women's mental health, child psychiatry, and psychotherapy. She has conducted professional workshops on emotional regulation skills in DBT and has been a speaker at the annual Kerala State Psychiatry Conference of mindfulness based interventions in psychiatry. She has also contributed to important research, including her recent publications on depressions among the pregnant women seeking antenatal care in South India, reflecting her dedication to both clinical excellence and academic advancement. Ma'am, on behalf of medicine, we are truly honored to have you with us today. We warmly welcome and invite you to enlighten us with your valuable insights for the psychosocial aspect of the cancer. Welcome, ma'am.
Thank you
Over
so
to you.
much, Joel.
Thank you.
Let me first of all congratulate and at the same time thank the organizers of Medicine for inviting me for on this wonderful topic. Let me, I'll start the session without much delay. I'll start screen sharing. If there is any problem, let me know in between. No problem. So I hope the screen is visible to you and I'm audible.
Yes, ma'am, you're audible.
Oh, thank you. So without much delay, let me begin my topic for today, which is psychosocial aspects of cancer. We know in this generation and in this decade, the cancer incidence has increased and the mortality has decreased thanks to the development in the medical science and the technological advancements that are happening. So, in the comprehensive care of patients with cancer, it is very important for the medical students to know the psychosocial challenges involved. It is also important to know the biopsychosocial model for improving the quality of life in patients and survivors of cancer. So we know in the biopsychosocial model, biology means the physical health, the genetic vulnerabilities, and the drug effects. It varies from person to person. Coming to the psychological aspects, it mainly involves the temperament or the personality traits of the patient, how they cope with day-to-day life as well as stressful situations, their social skills, family relationships, their self-esteem, as well as mental health issues. Coming to the social aspects, it includes the peers, influence of their peers or their friends or their social groups, family circumstances, and the family relationships. So these are the three main factors that affect any illness, especially illnesses that have a psychological component. And there's an interplay between all these three. So the psychosocial challenges we know are faced by mainly patients and the survivors, but we should also know that caregivers and the oncology and other medical professionals also face certain psychosocial challenges when it comes to cancer. Caregivers and medical professionals play an important role and hence they should be aware of the difficulties faced by the patients. Knowing about the psychosocial difficulties faced by the patients makes us better at giving the comprehensive care that the cancer patients deserve. So the challenges faced by patients can be understood from two perspectives, that is time and function. So based on the time and function, we can understand the different stages that our patients go through, that is pre-diagnosis. There is a life that is lived before knowing the diagnosis of cancer. Then there is a life that is lived after the diagnosis of the cancer. before the treatment, then soon after the treatment, and then the long term duration after the treatment. So the problems faced by the cancer patients differ in each of the stages. Each stage has its own unique challenges. So, in general, if we see the challenges faced, it includes deterioration of self concept because of uncertainty about the outcome. So, a person gets diagnosed with cancer, they're not sure if they're going to fully recover or how their future is going to be. This uncertainty, as well as the isolation, many times the patients have to be isolated because of a risk of infection, or because they need rest, and also because they are not able to function well. So both of these together affect their self-esteem. Second is the body image. So, if they undergo any surgery, especially if it is disfiguring, for example, amputation of limb or surgery of the breast, these are all these surgeries are the type where there is a severe disfiguration in the appearance. So, along with this, the chemo side effects like the hair loss, then loss of body weight, uh, paleness of the skin, so all this adds to their body image issues. Along with nutrition, we know most of the patients who suffer from cancer have reduced appetite, or because of the mucosal erosion, they're not able to eat well. So all this affects their body image as well. And usually there is a discrepancy between the ideal self and the actual self. So the patients who have cancer might have imagined a different life for themselves. They might have had made plans on how to live their life, or to travel, to spend time with their family, to excel at work. So when there is this disparity or the difference about between the self that they have imagined and the reality, so after the diagnosis, these all plans, there is this uncertainty, this may not happen. So this discrepancy also adds to the deterioration of their self concept, and all these varies based on the physical issues and the psychological vulnerability. The patients may also face sexual problems. There may be lack of interest because of their physical issues, and some may even feel they're sexually unattractive, either because of the diagnosis or because of their change in appearance. So, self identity in cancer survivors. Some people think of it as a part of the past, that they have overcome it and they are survivors of cancer. Some say it does not influence their life or identity, and some do not want to call themselves as cancer survivors. They don't want to have that label at all. So it differs from person to person. Next challenge they face is maintaining social relationships. So, since there is a deterioration in their self image or their self esteem, it can cause dysfunction in social functioning, and they may have poor social functioning, because of which this itself can affect their self concept. So, you need to understand this is interrelated. There may be a problem in their self esteem that prevents them from interacting in the society, and this itself, because of the isolation, if they're not able to interact well with the society, that itself affects their self-esteem. So it is interconnected. Coming to young individuals, there may be poor prospects and delay in finding a partner after the diagnosis of cancer. Then the isolation, like I mentioned before, rehabilitation, loneliness, and stigma. Very important, still very important aspect in our country, even in this century, is stigma. Many people consider this cancer diagnosis or the term cancer as something very dangerous, and they may tend to isolate or avoid contact with people diagnosed with cancer. So all this affect the quality of social functioning. Coming to treatment related problems. So, any person who may be diagnosed with cancer or any illness, we know there may be a fear of treatment. And in case of cancer, we can, obviously expect there may be anxiety about the side effects, recurrence of cancer even after treatment, then financial problems. We know the, treatment expenditure can be very huge in certain types of cancer. So they may be worried and emotionally distressed by the financial problems. Then there may be role changes. So in a family, a person might have a specific role before the diagnosis of cancer. He may be the breadwinner or he may be the decision maker in the family. But once he is diagnosed with this illness, the role may be changed. Somebody else, their spouse or their son or daughter, may take up the role of deciding things, taking care of other family members. So this also affects their emotions. Then coming to access, people who are far away from a city or a metropolitan city may not have proper access to reach a good hospital providing a good care for cancer. There may be accommodation problems. We know there are tertiary care centers which provide good treatment for cancer, but there may be accommodation problem. They may not find housing that is near to the center that is providing treatment for the same. They may also have concerns about the outcomes. Coming to the emotional distress, we know any person having cancer can have emotional problems, and they may have it at a disorder level as well. So we know major depressive disorder is very common in people who have been diagnosed with cancer. They may have a persistent low mood, crying spells, always thinking about death, or having suicidal ideas. So all this may warrant treatment for depression. Another common mental condition associated with cancer is generalized anxiety disorder. When the person is anxious about anything and everything, there's a free floating anxiety. If when they get up, the anxiety starts. When they have to talk to someone, the anxiety starts. When they have to go to the hospital, they feel anxious. So that is generalized anxiety disorder. Then adjustment disorder, which is very, very common in patients with cancer. When they come to know of the diagnosis, or when they come to know about the prognosis or the treatment options, they have difficulty adjusting to the reality. So they may have worries, reduced sleep, they may feel anxious, or they may again have crying spells, sadness that lasts usually less than 2 weeks. And some people, get to accept their diagnosis and take the necessary steps for treatment. Some people may not, and they may qualify the criteria needed to diagnose depressive disorder. Next is the PTSD, the post-traumatic stress disorder. It can occur after anything traumatic that has happened during the treatment of cancer or otherwise, especially surgeries, the pain after the surgery, or the experience they have had in ICU or ward, etc. So that the traumatic event that has occurred to them, it can recur in their mind. It can come as flashbacks, nightmares, and they may feel like they're reliving the situation that has caused this stress. So that is PTSD. Then coming to somatization. Some people, because of their emotional distress, may feel that they have pain than that is expected with a particular illness. They may perceive the pain as more than an average person. They may, without any reason also, they may feel aches and pains all over the body. So these are all somatization. Other emotional distress include shame, guilt, and stigma. Shame, for example, like I mentioned, when there is disfigurement or when there is a mask that can be seen by others, that is again causing problems in their appearance. Then guilt, for example, the person who has smoked for many years, he gets lung cancer. He may also have to deal with the guilt that because of my habit, now I am suffering and my family members are suffering. So that is guilt. Then stigma, like I mentioned, still people with cancer face a lot of stigma in our society. Coming to the problems faced outside the hospital, like I briefly mentioned earlier, economic burden. Not everyone can afford treatment, and some people may opt out of treatment because they do not have the financial resources required for a particular surgery or a particular modality of treatment. So, along with that, during the treatment and during the pains and the physical problems that they are facing, they also have to manage their financial affairs. They have to take care of their insurance papers, go to the insurance office, etc. Then comes the access, like I mentioned, there may in rural places especially, transportation, accommodation may not all be easily available. Then there may be inadequate support from the workplace. So a person working in a particular company or office before they were diagnosed may not receive the support that they expect. One second. So they may not receive the support that they expected from their superiors or colleagues because of frequent leaves or absences or their difficulty in working like before. They may face discrimination or negative perceptions of their work performance, and they may be, fired from their jobs, or they may be stigmatized or blamed or teased or made fun of about their cancer. All these also add to the emotional distress faced by the cancer patients. Coming to the challenges faced by informal caregivers, caregiving can be physically, emotionally, socially, and financially demanding. So, the informal caregivers are usually the family members, immediate family members, especially spouse, children, or their siblings. This can be very emotionally and physically draining. They have to deal with the diagnosis. They also have to accept that their closed one is diagnosed with cancer, and their lifespan may be reduced, or their time on this earth may be limited. Along with that, they have to take care of their uh, family member who has been diagnosed. And uh, along with the care taking, they may also have to take leave from their workplace. So there's the issue of unemployment, financial strain because a person is not able to work, and hence the financial strain becomes even more. Then there can be emotional problems as well faced by the caregivers. They may undergo anticipatory grief in case of patients who have terminal cancer or a late stage cancer. They may have to deal with the grief of the reality that they may have to live without this person. Then there can be issues of sleeping difficulties because of the anxiety, worries, or because the patient needs supervision and care 24 into 7. So, coming to the challenges faced by health professionals, it is first of all there is a very important aspect of patient doctor communication. So, if a doctor is not able to communicate properly with the patient or bystander, that itself can cause distress to the patient and later to the doctor also. The body language, the attitude, the level of knowledge, the level of empathy that the doctor shows is all important in building a good therapeutic alliance and building rapport with the patient and bystanders. So, most of you might be aware of the spikes protocol. So, what was spikes protocol for? So, spikes protocol is basically a commonly used protocol for breaking bad news. So, not just in cancer, it may be about disclosing the news of death. It may be disclosing about something life changing. It may be about the poor prognosis. It may be about telling or disclosing the information of a poor prognostic psychiatric illness, cancer, or any such severe illness that can be very difficult for the patient or bystanders to handle. So during these kind of situations, spikes protocol can be used. Spikes is the acronym for uh, the following steps that you can take during breaking the bad news. S is for setting up the interview, which means informing the bystanders and the patient that you are about to disclose something that may be difficult to hear, and setting up a proper place which has adequate privacy, which has adequate space for everyone to sit down and talk in confidence. So that is about S, that is setting up the interview. P is for assessing patient's perception, patient or bystander's perception. So how do you assess the patient or bystander's perception? It is by asking them, what do you understand, or what do you think of this illness? What do you think the stage of the illness is? These kind of questions give us an idea about their perception. Then I is about obtaining the patient or the bystander's invitation. So you can offer them a space for asking questions that they want to know. Then give the knowledge and information that you meant to give in a stepwise manner. So tell them the basic information like the diagnosis, what it means, which stage the patient is in, and if they are receiving and accepting it well and they want to know more about it, then you disclose the next set of information. So for this, you should also have a good knowledge and also prepare beforehand what the patient or bystanders may ask you. So that is about giving knowledge. E is for addressing emotions with empathic responses. This is also very important. It's not like you will tell them this is the diagnosis so, and then you say, okay, you people carry on, I have some other work. No, you also need to sit down with them and listen to their concerns, give them time and space to express their emotions. Some people may deny, no, I don't want to hear this. I don't agree. I don't want to listen to you. How can you say like this? How can you tell my parent or my wife is having this illness? I cannot accept. Some people may get angry. If there is any sign of hostility, you also have to take safety measures. Then comes the strategy and summary. S is for strategy and summary. So once you have underwent all these steps, the last step to do is to summarize that whatever you have told, make sure they understand, and then tell them the further steps to be taken. So that is about the spikes protocol. Then coming to the burnout. Most of the medical professionals who have to deal with oncology patients, so the radiation oncology, surgical, or medical oncology professionals, and sometimes the psychologists who are associated with the department usually suffer from burnout. It has three dimensions. One is emotional exhaustion. They may feel exhausted and overwhelmed because they're always dealing with negative news, and they themselves are supposed to talk about the negative news, and they also have to listen about the so many sad things. Second is about depersonalization. So depersonalization is when you detach from the reality, when you detach from the emotions that are usually expected from you. So you go through your work and go through the patient's patient related treatment, talk to the bystanders without actually dealing with the emotions. You somewhere ignore your emotions, you suppress or repress your emotions, and you are detached. You feel numb emotionally. That is the second one. Third is the low personal accomplishment. So even after giving your best, even after taking care of your patients, even after giving them proper treatment, you feel that you have not achieved or you have not done well, you have not done the best. So these are the three dimensions that are usually seen in burnout. So as we know, the healthcare professionals are the usual people who provide services to patients, and they develop a therapeutic relationship with them. They maintain an ongoing intense level of personal and emotional contact. So during the consultation, during the reviews, the patient and the bystanders may open up to the doctor about their own personal difficulties, the situation at home, what they think about the illness and how it may affect their future, and the doctor has to deal with it. So having a meaningful relation with them, and the patient feels relieved after talking to you, this can be rewarding. But at the same time, since you're dealing with lot of emotions, it can be stressful. So if you feel that these three signs of burnout, it is very important that you yourself seek help. So after understanding all these aspects, the negative correlates that lower the quality of life in cancer patients can be understood or summarized as the negative correlates being depression. A person having depression, psychological distress, and anxiety may not have a good quality of life compared to a person without it. And it is consistently associated with poorer health related quality of life across the survivor groups, avoidant or passive coping, or neuroticism. So it means, for example, avoiding, somebody is diagnosed with cancer, they say, no, I don't want to go to hospital anymore. I will live my life how much ever I can. I will not, go talk to the doctor, and I don't want any treatment. That is avoiding because they are stressed about it. They don't want to deal about it. So it is avoidance. Then comes the passive coping. So you just, listen to your family members or the doctor. You're not involved in taking decisions for yourself, and you let the things happen to you. That is passive coping. And then these are all neurotic kind of defense mechanism, and also always feeling worried, anxious all the time. These are all associated with lower quality of life. Likewise, other maladaptive coping styles, like you can, go and read about it. The maladaptive coping styles like displacement, where, I'm sad and frustrated with my diagnosis, I take the anger out on somebody else. That is displacement. Then denial, like I mentioned, I don't have illness, I cannot accept this diagnosis. These kind of coping styles also lower the quality life. Then comes the perceived social support. Coming to the positive correlates that are associated with higher quality of life are the social support. When they perceive a good social support from their family, society, and their friends, it improves their quality of life. They are able to, actively go through the diagnosis, treatment, and rehabilitation processes. So that is active or positive coping. Then resilience. Resilience is when you have the capacity to deal with day to day as well as difficult situations with a certain amount of optimism. Then comes the emotional or spiritual growth. Some people, in times of difficulties, they believe in, they think of the spiritual things and the purpose of life, what it means to them, what can be done with the time they have. So these kind of emotional and spiritual growth with a sense of coherence and finding faith and meaning in their life are all associated with positive or the higher quality of life. So it is very important also to know what can be done about these psychosocial challenges. So implementation, it is very essential to ensure that there are routine distress screening and step care pathways. So having a simple distress questionnaire kept in the OP of a medical professional who deals with oncology patients can help them to detect whether they have any emotional distress. And they can be referred to higher, they can be referred for a mental health professional through stepped care pathways. Then, when dealing with the patient being culturally sensitive, family inclusive approaches are also helpful. So, why this family inclusive approaches are important is because usually when a person is diagnosed with cancer, there can be looped communication. So, the doctor is taking rounds in a hurried manner. There is lots of work to be done. So, he goes through his rounds routinely without actually disclosing what are the future treatment options or asking the patient's opinion. So he thinks the patient bystanders will communicate about the nature of the illness and treatment option to the patient. And the family thinks, okay, doctor has already maybe spoken to the patient. So there is a lot of miscommunication, and what happens is the patient does not get a clear picture of what is happening, and they feel, isolated further. So it is always important to be sensitive and to, talk to the patient openly in the presence of family members. Then coming to navigation, care navigation, and financial counseling. You can guide the patient and patient bystanders how to go forward with taking care of a patient. And it is always a good idea to have a social worker or somebody good at, financial counseling. Then to track outcomes like the quality of life questionnaire, WHO quality of life questionnaire or a distress thermometer, these kind of scales can also be used. Then coming to the supportive services and interventions, there should be integrated supportive care, which includes psychology, psychiatry, social work, rehabilitation, and nutrition, along with the oncology teams. So the goal is to have a coordinated, patient-centered care addressing the physical and mental health together. Then coming to the psychotherapy and counseling. You might be aware of the CBT or the cognitive behavior therapy, mindfulness based strategies, then helping them to train with coping skills. Then, if necessary, add medication when indicated. For example, it's just not a simple anxiety and they're dealing with generalized anxiety disorder, or they may be dealing with a major depressive disorder. These all warrant medical management as well, along with therapeutic, psychotherapeutic management. So with this, the outcome that we expect is reduced distress, reduced incidence of depression, and improved adherence and quality of life. There should be also provision for survivorship services, symptom management, and education. Then peer and online support. Moderated groups, people who have gone through cancer, their caregivers can have support groups online or offline. There may be communities that openly discuss about the difficulties they have gone through and the steps they have taken to help them overcome. So it brings a signs of, it brings a sense of coherence, a belongingness that I'm not alone in this difficult time. There are people like me who have gone through and found a solution to this problem. So it helps to reduce isolation and share practical coping and resources. So there is normalization, empowerment, and sustained engagement. For people who are from remote places, telehealth and digital tools can be used for follow-up, giving them counseling, or to screen them for any kind of distress. So the usual challenges that we face, some of them we already mentioned, are the stigma and the cultural attitudes toward the mental health and cancer. The financial and logistical hurdles that includes the transportation, cost of treatment, accessibility, etc. Then fragmented care and limited behavioral health workforce in oncology. So in many places, there may be an oncology center like the regional cancer center where for getting mental health support, they have to go to another place. So this fragmented care also limits their quality of life. Then religious and spiritual beliefs that may delay them from seeking help. For example, they believe through prayer alone or through doing some religious practice alone, the cancer may get cured. So this may all delay them from getting the help that they deserve. So thinking of the future directions or the solutions, now we can take certain actionable steps like routine distress screening, anti-stigma education to the patient bystanders, and as well as to the community or society in general, and including the religious or the community leaders in spreading awareness. Telehealth and digital tools can be used to widen the access. Also, it cuts down lots of cost through telehealth access. Then personalized evidence-based interventions and ongoing research. So that is about psychosocial aspects of cancer. I hope you people have understood. And if you have any doubts, you can unmute or ask in the chat box. And let me once again thank the coordinators of MITUSIN for giving me this opportunity. I believe it is very useful for MBBS students, keeping these kind of online sessions. Thank you.
Hello?
Hello, am I audible?
Yes, ma'am, you're audible.
Guys, is there any questions? You can drop your questions in the chat box. There is a question like, is there any mental health care provided in India for cancer patients?
Yeah, definitely. But mostly it is, when somebody refers, some oncology consultant refers the patient for to the psychiatrist or the psychologist. Routinely, I don't think it is given to everyone. It is usually the oncologist who talks to the patient and gives them the adequate information and the supportive care in whichever possible they can. But there are in many places like the regional cancer centers, there are psychologists and sometimes psychiatrists who are employed there, who are actively involved, but not everywhere.
Thank you for your explanation, ma'am. And I guess there is no more questions in the chat box. Thank you for your time, ma'am. We'll go to the vote of thanks from Zoel Josh.
Yes, sir.
Sorry,
Okay.
sorry to interrupt. There is one more question, I guess. Should
Yeah,
we make it as a routine as a part of management of cancer to go to psychiatric evaluation to screen?
Yeah. It is always better. The thing is, in most of the institutes in India, the time is very limited, but it is possible to give a simple questionnaire, like the perceived distress questionnaire, or the quality of life questionnaire, or even uh, a BPRS scales that can be given to the patient and they can themselves answer it. Hmm. Instead of us administrating, it can be given to the patient and you can get the answered questionnaire back to us. That is actually easy. Though the implementation, how much it is happening uh, in India, I cannot guarantee.
uh, thank you, ma'am. We have got one more question. How is psychiatry as a field, ma'am? Is it a growing field or yeah, this is the question.
Okay. Okay, just out of our topic of discussion today, but definitely I can tell you psychiatry is a growing field. If you are, really interested, it is a growing field, and people are becoming more aware about mental health issues. So, and people are more ready to seek help. So, it is definitely a growing field.
Ma'am, there's a question from YouTube, a live chat. Can antidepressants given to the cancer patients under chemotherapy, is it safe or any drug interactions will be there or how to be aware of that? This is the
Antidepressants,
question.
you are saying?
Yeah, yes, ma'am.
Okay. Yeah, most of the antidepressants, they are selective serotonin receptor inhibitors, and they do not generally have much interaction with anti-cancer treatments. But certain medicines, certain antidepressants, can, through the CYP inhibition, through the enzymes that are involved in metabolizing, can have some interaction where we may need dose adjustment, especially antidepressants like the paroxetine, fluoxetine, etc. They in such cases, the doctors will have to coordinate with the psychiatrist in adjusting the doses.
Yes, ma'am. Thank you, ma'am.
Uh,
The next question
one
is
One more
sure.
thing I wanted to say was tamoxifen. Tamoxifen commonly interacts with tamoxifen, that is an anti-cancer treatment that commonly interacts with antidepressants. That once I mentioned paroxetine and fluoxetine.
Okay. And the next question is, if the patient is keep on angry to the doctor for their condition, what should we have to do to them, ma'am?
Yeah. So when somebody gets to know about the diagnosis, anger is a valid emotion. It is, it may not be a good defense, or it may not be a good way to express their emotion, but it can happen. So giving them time, listening to them patiently, and addressing their concerns initially is very important. But of course, if they are angry each time and they're becoming verbally or physically aggressive, then the consultation cannot go on. You will have to cut the consultation then and there for your own safety purpose. And you can also tell the patient or bystanders, I understand your emotions, but if you can, have a proper conversation when you're ready for that, when you have calmed down, I can continue talking to you.
Okay. And the next question is, how should we deal with the patients or attenders who are not very cooperative in nature? Yeah.
Cooperative for what? This is a very general question. Vague question. I mean,
Okay.
cooperative in what way? If they are not cooperating for the cancer treatment or talking with you, you can be more specific. Maybe I can guide you.
So, about in communication, it's
You meant in communicate. They're
communication.
not cooperating. Okay. So if they're not cooperating, you will have to inform them that there is a problem in not communicating properly. If you are not willing to talk, then I cannot help you further. But if you have any concerns or anything that is bothering you, then I can help you address it. If they are not cooperating, then what else can be done? We can give them the information of not being cooperative. What are the risks of not being cooperative? And try to make them understand.
Okay, thank you, ma'am. And the last question is, how do we differentiate normal emotional stress from clinical depression in oncology settings?
Okay.
Yeah.
So in clinical depression, the severity varies. Okay, the severity is more. So in normal, there's nothing like normal emotional distress. Only thing we can quantify is the severity and duration. So a person who is going through a difficult time, it is normal for them to feel anxious or sad. But if the anxiety or the sadness is pervasive, it is always there. It does not change with time. If something good comes, if something funny comes, their mood does not light up. They're still not able to enjoy. They're always worried or crying, and it is affecting their day-to-day functioning. Then we'll have to think of a disorder like the clinical depression.
Okay. We got one more question. How should doctors handle situations where family members request non-disclosure to the patients or vice versa?
Okay, so any person who is above 18 has the right to know. Okay, you have to. If a family member says you should not tell about the diagnosis to the patient, then you'll have to inform. If the patient asks me, yeah, about the diagnosis, the patient has the right to know about it, and I will have to inform the patient. But there is something called privileged communication. If you feel that the patient does not have the capacity or the emotional strength to deal with the severity or the severest of the complications, you may, withhold certain information like the poor prognosis aspect. And, the worst case scenario, you need not explain to the patient then and there. Only if the patient is actively asking and he is having the capacity for it, you can disclose. But the basic information every patient has the right to know. Also, vice versa, if the patient needs every cancer patient, of course, needs a family member or a bystander to help them in the treatment, and for the technical aspects for getting the medicine, getting the financial help. So you'll have to tell the patient, I may have to inform the patient bystander that you need so and so kind of help. Okay.
Yes, ma'am. And one more question. How do cultural beliefs in our settings influence the truth-telling practices in cancer care? And what are the psychosocial consequences of patients when information is withheld or filtered?
Truth telling practice, you mean it's a similar question? It's a question similar to the previous one, I think. So yeah, I think I already answered. Cultural beliefs, you cannot really say some, like I mentioned in the topic discussion, there is many times there's a loop communication because of misunderstanding, and people do not want to handle or talk openly about the diagnosis and treatment. So the patient and the bystanders, they do not openly discuss about the illness or the treatment. They talk to the doctor, and the doctor thinks they are talking to each other, but they may not be actually talking. So that kind of cultural aspect is there, more of a social kind of aspect. And psychosocial consequence of not telling everything, or you mean the truth? Okay. There can be psychological distress if you withhold major information from the patient or the bystander. They may get distressed once they get to know about the diagnosis from someone else, or very late in the stage if they get to know. They may feel distressed, they may feel isolated or cheated even. Okay, I trusted the doctor and you did not tell me. So these kind of problems can happen.
Yes, ma'am. Thank you, ma'am.
Okay.
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 Yes, ma'am. We'll go to OTA. Thanks. OTA. Yeah. As we come to end of this insightful session, it is my privilege to propose vote of thanks. On behalf of this entire medicine team, I extend our heartfelt gratitude to our esteemed speaker, Dr. Aishwarya R. Kamath ma'am, for sharing her valuable knowledge and practical insights with us today. Ma'am, your clarity, depth of expertise, and compassionate perspective on mental health have truly enriched our session. We deeply thank you for your time and guidance. I would also like to thank our participants for their active management and engagement through the persons, which made the session interactive and meaningful. A special word of appreciation to the medicine organizing team for their dedication and efforts in making this webinar a success. Thank you once again for everyone for attending this event. Have a wonderful journey ahead. Thank you, ma'am. Thank you.
Thank you.
Meeting is over, guys. You can deal.